And we are live, Senators.
Good afternoon again, everybody. This is the Vermont State Senate Committee on Institutions. Today is still February 8th, 2022. We have shifted gears this afternoon to talk about Mental Health Advocacy Day. Our first witness was planned to be Pam McCarthy, the president of the Vermont Family Network. She was unable to make it this afternoon and has instead submitted written testimony, which you can find on the committee's website. We do have with us Zachary, is it Hazid or Hozid, or how do you pronounce it?
Hozid.
Hozid, who is the staff attorney for Disability Rights Vermont. Zach, I don't know if you've ever been in front of this committee before. I don't recognize you. You may have been, in which case you'd be totally insulted that I haven't recognized you. But having said that, I'm going to give you the same spiel I give to virtually everybody who comes on to join us. We have a YouTube audience that we have no idea who's actually out there, but we do have people out there. So my conversation today hopefully will result in a level of vernacular, if you will, that everybody in the world can understand. If for some reason or other you venture off into something that is very familiar to you, but maybe unfamiliar to the world at large, I may interrupt you and ask you to explain what A, B, or C means. That's not because I'm trying to be rude. It's just because I want to make sure everybody that may be watching us has a basic understanding of what's going on here today. I do understand that this is Mental Health Advocacy Day. Normally, we would be at the State House and enjoying the company of many folks who were coming out to tell us about various aspects of Mental Health Advocacy Day. At the moment, you are the person on target for this committee to tell us all about why you're here. So when you introduce yourself, the other thing that I would ask is that you give a 30-second or so biography on who you are, how you came into your current position, and then we can have you start into whatever the testimony is you wish to give us about the subject matter at hand. Any questions before we begin?
No, that was a great introduction. Thanks.
Okay, well, welcome to Senate Institutions.
Thank you, Senators. Good afternoon. Thanks again for scheduling this, and I appreciate you rescheduling it so it could work, at least for my schedule. So I'm Zach Hozid. I'm the current legal director at Disability Rights Vermont. I've been at Disability Rights Vermont for about four and a half years. I was a staff attorney for about 4 years, and I've been a legal director for the last 6 months or so. For those who don't know, we are the designated protection advocacy system in Vermont. We're federally recognized as the protection advocacy system, and so our mission is to promote the rights of people with disabilities statewide. We are also the state designated mental health care ombudsman, and a large part of our role is serving folks with mental illness and making sure that their rights are being followed and address issues when we see them. So as you know, I was invited to come here and testify about some of the issues that we're seeing and put some ideas into your head, and I'm happy to answer any questions that any of you have. And I believe I did submit some written testimony that you should have as well. So you know, often this committee is said to be focused on the brick and mortar aspects of our system of care. And so I will keep my testimony mostly focused on that, but recognizing that it's not in isolation. The buildings, where they are, what's in the building, what type of building is all intertwined with the type of services and the staff that are part of that building. You know, you don't play basketball on a football field. So what you're doing in a particular place matters a lot. And there's often been discussion about, you know, where clearly there's a continuum of care that folks receive, and most people, most of the time, receive the services they need in the community, at home, in schools, and really the bulk of our efforts really should be on those services which prevent folks from getting to the higher end of the need of care, and serve people much better and allow people to thrive within the community and continue to go to school, to work, to be a part of their families. And there are times where people need a particular place to go, whether that be very short term for a couple of hours, or it could be a little bit longer, a couple of days, a couple of weeks, or it may be a little bit longer. Most of those facilities and those services can be in community-based placements where people still have access to the community, to their family, to their work. And then occasionally it may be appropriate for someone to be in a secure setting for a very limited amount of time. But that's relatively rare, and shouldn't be the main focus of our efforts. And one of the big things that we often see in our role is that really the services provided within those higher end secure facilities is fine, but there's not the placements in the community to go afterwards. We often hear from folks that the community treatment that they need, whether it's counseling, whether it's employment services, housing, that those things they're not able to access all the time, and that leads to a crisis, which then they end up in hospitals, in prisons, in different locked facilities, and then from there, if they're going to some sort of step down placement, they often have a hard time finding or securing those placements because they're just not there. The other piece that we're all very aware of is the staffing crisis. There's a huge crisis in our system right now with staffing, particularly in community placements, and making sure that there's a number of community placement beds that are offline. There's also a number of inpatient beds that are offline because of lack of staffing, which again shows that really the place to invest is in our staff. And so when we talk about the brick and mortar in the buildings, it's part of it is how do we allocate the scarce resources that we have? Where do we put our resources and invest? And again, most of the time, most people can be served adequately in the community, and it's a matter of having the right funding and the right services, and the right staffing, and the right options for people statewide so that they can access those services. And then for folks who are transitioning back to the community from a secure facility, that they have those services, that they have the case managers that they may need. They're able to navigate the system and attain housing and obtain various supports. And if they're going to some step down facility, that facility is there and has the staffing to serve them. The other thing that we often see is this issue of sort of siloing, that there are oftentimes services that are designated for mental health or developmental disabilities, and they're often separate. We're starting to see a bit of a breakdown of that, and that's encouraging. There often are people who have diagnoses in both and need services for both, and so it's really important that there's crossover for that, both in terms of the services and also in terms of the facilities and what facilities are providing in terms of services. And I think you heard a bit earlier in the week about the need to really look at our community placements and community services. And again, what we've been hearing from a number of folks that we serve is that they're often stuck languishing in secure facilities, both prisons and inpatient units, because those community services just don't exist or are not there. And so really there needs to be a development of those services. Things like developing more peer supports and respite centers, those are very important and beneficial to the system so that people can access the services they need and be within their community and continue to thrive. Part of when I was invited to this, part of the initial invitation or call was looking at youth placements. And so that's another area that we've been very involved with. You probably are aware of the Woodside facility in that case, and we're involved monitoring there for quite a while and involved in some litigation on that. And in terms of finding, again, building some sort of replacement for that, if you will, or some sort of facility to house children. Again, most children can be served in their community. It's better for kids to be at home with their families, part of their community, able to access school services. But there are times where children need to be in facilities. We're seeing emergency departments overrun, not overrun, but sort of overflowing with kids that are trying to get mental health services. Again, largely because a lot of those services just don't exist in the community. And so the emergency department becomes the last resort. And so we're, at this point, we are seeing a point where youth are needing to go somewhere. Unfortunately, they're going to a place where they often don't need to be, aren't getting adequate resources, and are then waiting there for long periods of time. And so really there needs to be a question of looking at what is the data, both quantitative and qualitative, say about, what are these children and these families really needing? Is it a big locked facility? Probably not. It's probably, more home and community-based and school-based services. And there may be a need for short-term, less than a day, a few hours, couple of days, place, respite center, sort of crisis center where kids can go, families can go when there is a crisis, that can be addressed, there, and also having things like mobile crisis units where people can go to the family and serve them where they're at, as opposed to forcing the children and the families to go somewhere else. Again, particularly an emergency department, which often is not the appropriate placement. And then the question is, from there, where are the children going? Are they going to inpatient units or really needing that? And most of the time, the answer, I think, is no, that's not what they need. They need, again, those community services and long-term services in some instances. Or again, there's a lot of children that need mental health and developmental disability services. And from our work and perspective, those are the children that often have the hardest time finding the most appropriate placement to meet their needs. So I think that's really where the investment of services and facilities should go, is serving those children, those families. The other question would be, how many youth are currently being served out of state? And is there a way to bring many of those children back into our state so we can serve them effectively within the state? And that is data that I wish I had a few today, but I don't. But I did recently put in a request with Department of Children and Families to get some of that data, try to help understand what is the need in our state for these services. One proposal has been to, I think, invest in over $3 million to retrofit the facility in Windsor, the old prison. That proposal is very concerning to me. It reminds me a lot of Woodside and some of the issues there. I don't think that facility was ever fully retrofitted to actually therapeutically serve children. I didn't find it to be particularly warm and inviting as a place. And it's very difficult, I think, to do that with any prison. The other question, again, would be, what is the need? Do we really need 10 beds, 10 locked beds for children who are really involved in the criminal justice system? I think probably not. Again, the question would be, let's look at that data and see for sure. It could be that there are kids being out of state that have that need. But again, my hunch is that that's not the case. And I think I've heard folks at DCF testify previously this year that there just aren't very many children that fit that need. But again, there are children with mental health needs and developmental disability service needs that do need placements and therapeutic placements. And I think that's where the bulk of our resources should be focused, is where can we develop those services and those placements to get the children there. So those are some of the general things and themes that we're seeing. And again, thank you very much for your time this afternoon. And if there's any questions you have now, I'm happy to answer them, or any questions later on, I'm always happy to come back and talk to you folks.
Committee questions? Senator Ingalls.
Thank you, Attorney. I appreciate your testimony and insight. As I was in a meeting yesterday, the committee already knows where I'm going with this. Deputy Commissioner Crump had made a statement, and then she kind of backtracked on it, that the state was looking more of getting not having brick and mortar facilities so much as holistic healing places. And as we look in this committee, we look every time that we meet, it seems that we're talking about millions of dollars that are going, that are being asked to fund brick and mortar buildings. Where do you see the state headed down that path of caring for our mental health crises?
Well, I think where, what the data is showing and where the state is headed, and where the, quite frankly, where the federal law points us in the direction to, is of more community placements and resources, and a little less of that brick and mortar. But again, there are times where there is a need for buildings for people to go. But I think the direction we're headed is they're going to look very differently than they are now. We're not going to have as many secure facilities. We're not going to have as many long-term facilities, and more short-term placements, more sort of living room model type placements where people can go for a short amount of time and transition out, and more community-oriented placements. And I think the focus should be on investing in those services, and then transitioning the current buildings we have that serve on the higher end, as we find that less and less we need those beds. For example, we find that the recent, they're currently building the secure residential placements to replace the Middlesex facility, which has, as I understand it, 16 beds with 2 8-bed wings, with the idea being that they could possibly have different uses. And so I think we'll start to see sort of more options like that, where things can be adjusted and changed as the needs change. So if we find that, as a state, we don't have 16 people needing a secure residential placement, but we have, say, 7 or 8, we can use one wing for that, and we can use another wing for some other purpose. I've been at some meetings where some folks have talked about folks who are currently incarcerated and have psychiatric needs that can't be met there. Maybe they could go there for short term. We may also be able to, again, retrofit it to be a more, one wing could be locked and another wing not, which could be a way to transition folks, again, back into the community. So that's what we're seeing.
What's the data show, though? I mean, I understand that everybody wants to wave the wand and wants to believe in a better way to heal people and to keep them, not only keep them safe, but keep the public safe. But what's the data show that's needed? Does the data show that more holistic places are better, or does it show that there's just a need to protect both the people in need and the public? I'm just curious about that, because we're talking about spending a lot of money, and I just don't want to go back down into having a facility. I mean, there's a lot of people, there's a lot of communities that just don't want these places to begin with, as we're discovering. And so it's just a lot of, it just seems like we're spending a lot of time trying to figure all of this out. And I just want to be sure that we're not going to be building something or going down a path that 5 or 10 or 20 years later, we found out we spent $300 million only to find out that isn't the right direction.
I think that's a very good question, sir. I think we really do need to look at, what does the data tell us in terms of what people need and what's most cost effective, and then make determinations based on that. I think that the data has shown us historically that locked facilities and taking people out of the community is not helpful in the long run for people's mental health and their success in the community. And so in terms of developing people individually and providing services they need, and developing our communities, more community placements and ways of providing services to folks to stay in the community and stay at their workplace and engaged, those tend to have better results. And peer supports, those have better results for people long term than being, taken out of your community. And I think folks at Department of Mental Health and folks at Disability Aging Independent Living will have more insight in terms of what specific types of placements, and hopefully more data in terms of what the results show for treatment. So I think that's really where the need is in terms of serving folks.
So I heard a statistic the other day, and forgive me for not knowing, and it's a little outside of what we're talking about, but it's the same idea about brick and mortar structures, that two of the places that we have to help people kick the whatever addictions that they might have, that they're not in fact half full, and they actually have placement needs. And I don't think that it could be an arguable point that we're probably in a pandemic of opioid addictions in this state, because of the function of those buildings and the way that they are. Those people can't be helped in those types of settings.
Yeah, I think sometimes it makes sense to have settings for people to go to receive treatment and services. And again, in terms of, if it's a question of building anything more, I think, what the data shows is the current sort of higher end on the spectrum, continuum of care facilities, the locked units, the more long-term placements, those places, we have an adequate number of beds. We don't currently have an adequate amount of staffing to fully run and operate those beds. But for years, we've known that the more community-based services aren't there and the home-based services aren't there. And so once folks are in those facilities and in those placements, getting out often takes much more time than clinically is needed, because they don't have anywhere to go. Also, big part is lack of adequate and affordable housing for people to go and live in, and access to employment is huge as well. So again, there are times where those facilities are needed, but I don't think currently we're in a situation where we need to build more on the higher end of the continuum, but we certainly need to build more on the lower end and make sure we have the staffing and the services available.
Any other questions? So Zach, we've got this predicament. We shut down Woodside. Woodside was a place where the higher end of the spectrum could be accommodated, even though it was not the best, but we shut it down. And presently, the higher end of the spectrum is being treated in hospitals, which is a place they cannot continue to be. We're getting too much pushback from hospitals about how dangerous that environment is. Some are being brought down to 204 Depot. That's got limited capacity. Some are in hospital emergency rooms, which is definitely not a place they need to be treated. So we get these proposals. One in Newbury that is not state land, is owned by an out-of-state corporation, and we could spend millions on that facility to bring it in line with what would be needed for these higher spectrum individuals. But we wouldn't own the land, we wouldn't own the property after. We would be subjected to whatever the corporation wants to do. On top of that, the town has expressly stated it does not want it there. And the reality is services that these higher spectrum kids would need are not anywhere near that facility. We have another option, which is in the town of Windsor, where the town apparently doesn't want it. It is state land, is buildings that are not conducive and would have to be retrofitted for many millions of dollars. How do we solve this problem? I've been on this committee a lot over the past 11, 12 years. And this has been an ongoing conversation, and I'm just not sure how we get to the end of this answer. Suggestions?
I wish I had a great answer for you, Senator, but I don't. I have a lot of questions, which is, what is the data? What is the need for these children? Part of it is how many children are we talking about on this higher end of the continuum of care? The other question would be, I think before you answer the question of how many, it's what kids, what services are these children needing specifically? To what extent, once we can identify what needs our children and families are having, the question becomes how many of those really can we develop services and in the community for? And one of the things that we saw from our vantage point is when Woodside was shut down, a number of children that had previously been there or previously may have gone there were provided additional services and able to stay in various community placements and often able to stay in their home with the right supports. So that becomes a huge question is, do we really need a facility for all these kids? And the answer is no. So then for those who do need some sort of facility, the question becomes, what services specifically do they need? How do you design those services? Where are these placements? I think having probably a few smaller facilities, maybe 3, 4, 5 beds, at least 2 in different ends of the state or more, so that children are not shipped across the state and can ideally stay closer to home, would be better. And then, again, how do you structure these programs? And then, then how do you develop the services? And then from there, what's the best building and location to do that? And I don't have clear answers to any of those things, but I think we're all trying to find the answers.
Okay. I was hoping for a magical silver bullet there, but it doesn't sound like you have one.
I don't, but if I think of anything, I will let you know.
Okay. Any other questions, committee? Zach, appreciate you coming to join us this afternoon. Very good possibility we may have you back. We don't have the capital bill yet. There will be conversations within the capital bill about how, what, and where to spend dollars. You may have an opinion on that subject as it develops. And if that is the case, then you may have an interest in wanting to come back. Please let us know.
Will do. Thanks so much.
All right. Thanks for coming. Committee, we are going to stay on the same conversation, but we're going to shift a little bit to a report on Vermont's institutions for mental disease. And now we are talking with Jenny Samuelson, the interim secretary of the Agency of Human Services, and Ashley Berliner, the director of Medicaid policy for the Agency of Human Services. Ladies, good afternoon and welcome to Senate Institutions. I'm Joe Benning, the committee chair. Ashley, I know I've seen you on several occasions. Jenny, I'm not sure you and I have met before, but let's pretend for a moment we haven't, and I will give you the same spiel I give to all the witnesses who are coming before our committee. We are on YouTube, and YouTube presents a potential audience of unknown numbers and unknown characteristics. I am going to assume for the purposes of the conversation that there will be people out there who are being introduced to not just the committee process for the first time, but also to how the various functions of state agencies become involved in the conversation surrounding the Capitol bill and this institution's committee. In other words, as you are testifying, you may be very familiar with the language that you are using. You may assume that for the most part we are as well, but I will presume that there's an audience out there that is definitely not. So as you're giving testimony, if you happen to drop into a vernacular that you understand, and it red flags for me the idea that perhaps some more explanation is needed, I may interrupt your testimony, not to be rude, but just to simply say, can you tell us what X, Y, or Z actually means and how that fits into this picture? And that's all for the benefit of our unknown audience out there in YouTube land. I have, Jenny, you up first on this schedule, but I don't know whether or not that was the plan for the two of you as to who wanted to go first. But in any event, Jenny, I'll introduce you first and say, welcome to Senate Institutions. The floor is yours, as they say.
Thank you, Chair. I appreciate your time and your committee's time this afternoon. For the record, I'm Jenny Samuelson. I'm the interim secretary for the Agency of Human Services. Chair, if it's okay with you, what I'll do is I'll walk through a general overview of where we are with the Institutions for Mental Disease proposal, and then I'll pause, and Ashley and I will work to take questions from you as at your discretion, and the committee versus Ashley doing a formal presentation if that works for you.
That would be perfect. And let me say one other thing I forgot to mention is, as you introduce yourselves, if you could give us a 30-second presentation on your biography and how you fit into the process of government, how you came to be in your positions. It's always helpful for those who are out there in YouTube land.
Great, thank you. So I'm the current interim secretary for the Agency of Human Services. I've been working in state government since 2005. Specifically was one of the founding members of the Blueprint for Health, and then later on worked in the commissioner's office, and then was the deputy commissioner at the Department of Vermont Health Access. During the pandemic, moved to help support then Secretary Smith as the deputy secretary, assisting with a significant portion of the work related to COVID. My current work is here in the Secretary's office and working closely with DEVA and with Director Berliner on the 1115 negotiations. So the 1115.
Having said that, though, you're going to need to explain what
the 1115 is, exactly where we're going next. So the 1115 waiver in Vermont allows Vermont to more flexibly spend Medicaid dollars to provide services to Vermonters who are enrolled in Medicaid. Right now, Vermont is currently in the process of negotiating that waiver with the Centers for Medicaid and Medicare. It allows us specifically to make investments above and beyond what would normally be eligible in a typical fee-for-service Medicaid world. The current elements of the Medicaid 1115 waiver that we are negotiating with CMS really are focused in three key areas. One of those areas are what flexibilities we have and what's allowable underneath our program. The second is the amount of funding that we receive in over time, the amount of funding that's in our base budget, and also the trend over the next 5 years. And then the third area is specific to what we're talking about today, which is the exception that we have for funding for institutions for mental disease in Vermont. So institutions for mental disease is a federal definition. It's not a definition that we've chosen here in Vermont, but it's any inpatient facility that is over 16 beds where the primary treatment is for mental health, or if it's over 16 beds, that it exceeds 50% of the total capacity of that organization. So in Vermont, an example of an IMD is Vermont Psychiatric Hospital in Berlin, where it is a 25 bed facility. Ashley, you look concerned. Where it's a 25 bed facility, and its primary purpose is to provide treatment for individuals who are experiencing and need treatment for mental health. Another example that we may see come up in the future is one of our hospitals who chooses to integrate and add mental health beds. And it would not be considered an IMD as long as it's less than 50% of the overall capacity of that hospital. So for example, if Central Vermont chose to do it and it was at 40 beds or less, it would be less than 50% of their capacity.
Madam Secretary, could I just interrupt you for a moment? The bed space we're talking about now is strictly for adults. Is that correct?
It is strictly for adults. It is not related to children.
Thank you.
Yeah. So there are three primary locations right now. The Lund Home has previously been included. The Vermont Psychiatric Hospital and Brattleboro Retreat are some of the areas of concentration for that negotiations. And I can't go in depth right now in terms of what the negotiations specifically are, but we can talk in broad terms about what we're looking at. Specific to your community, as we look forward, similar to what was discussed earlier, as we look forward to looking to build additional space in Vermont, in order for, and I should be really clear that this is in order for it to receive Medicaid funding. IMD is a term of art for Medicaid. So in order for any facility that we build in Vermont to be eligible for Medicaid funding, it would need to be less than 16 beds, or it would need to be less than 50% of the occupancy of that organization. Some exceptions that folks may want to think about and consider are the forensics facility, which I know your committee has had significant discussions about. It is not eligible for Medicaid funding and therefore is not bound by the rules that the IMD is for Medicaid. The place where it comes into our negotiations in our waiver with CMS is that for those of you who are aware, the current Vermont Psychiatric Hospital is 25 beds and it exceeds the IMD. It falls into the IMD criteria and it exceeds the 16 bed capacity. The reason it's a component of our negotiations with CMS is that when we originally built the Vermont Psychiatric Hospital, we had sought approval from CMS, and at that time, we believed that the agreement was that it would fall within that. Because it is larger than 16 beds, Vermont over the next waiver period can expect, if we are bound to the rules for IMD, to see a tapering off of the availability of funding, Medicaid funding available for that facility because it exceeds the 16 bed capacity. So again, where it comes mostly into play in this committee is related to any new build and the size and the capacity of those facilities as before. So that's a lot of information. I'm gonna pause there and see if my colleague Director Berliner has anything to add to that. And then I'll turn it back over to you, Chair Benning.
So Ashley, before you begin, Senator Ingalls had his hand up.
It seems like we have a need that we can't fill, but it always seems like we're talking about reducing beds and reducing beds and reducing beds and reducing beds and reducing beds. I don't know. I don't get it. I don't get it. I mean, I understand that we have a 25 bed capacity, but for some reason we can only have 16. What's it matter? I mean, at the end of the day, aren't we here to help people, to get people better and to put these folks where they can be helped the most, and honestly to protect the public? You know, whether it's in mental health or whether it's in the prison system or wherever it's at, it just seems to be that we can't do anything really to put them there. We got to reduce them, but yet there still is a demand and a need to help these folks.
So I'd like to, if it's okay, to address that by breaking it down in a couple of its component parts. So this is very specific to inpatient care. And the goal, I think, at the federal level and in Vermont is to ensure that people receive the care at the least restrictive option possible, the one that allows them to engage more wholly in their community and their lives. And so the goal in Vermont has been to significantly build the capacity of the community system of care or the residential system of care while making sure that we still have enough inpatient beds. in Vermont, what we can, I think it really can be divided into two different distinct components. I heard the previous person who was testifying really speaking to the children's system of care. The IMD doesn't apply to that. And I think the other is the adult system of care. In addition to wanting people to be in the least restrictive component as possible, there is a goal to trying to make sure that they get integrated care. So, so the individuals are not just being treated for their mental health, but they also have the opportunity to be treated for their physical health. And so it's not necessarily that every facility has to be less than 16, but that individuals may be better treated through a model of care that is integrated, for example, with a hospital. We've had clients, as an example, who like to swallow elements. It's been very difficult to place them because they need to be near a medical system of care, or individuals have higher degrees of chronic or other illnesses. Being able to be treated for that while they're receiving treatment is a goal. So I want to divide it out into those two parts. One is the community system of care versus inpatient, and making sure inpatient is integrated. And then the second part is that there are very different needs in our adolescent and our adult system of care. I think, as you heard before, our children's system of care, it is at about 50% of its capacity right now. And so trying to strengthen that system is a priority.
So I hear could be, would be, might be. I that's what I hear today. And that's what I've been hearing. It seems like we're talking about theory, and this is what we'd really like to do. We'd really like to have it this way. And then, but in fact, what happens after we find out years down the road that maybe what we were doing was okay, we just need to manage it better. Maybe with what this new direction we're trying to go isn't the right way. How do we know that?
Yeah, I think that's a good point. There are two things that are on the horizon. One, in the children's system of care, the Department of Mental Health is looking to diversify the types of providers who are providing inpatient treatment, and is currently seeking bids, has an RFP out for inpatient beds. The second piece, I think we will likely see some of our hospitals who can provide that integrated mental health and physical health treatment put in to expand their capacity to also do mental health treatment. That's in the very near term. And so it's likely to see a shift from these standalone facilities to more integrated care in the very short term, in order to address the key needs that Senator, you've identified.
Do you have a follow-up, Russ?
I'm good for right now.
Okay. Ashley, welcome to Senate Institutions.
Thank you for having me. I'm Ashley Berliner, Director of Medicaid Policy. And I have been with the state for 11 years now. I started in epidemiology at the health department and moved into Medicaid a few years later, and have been at Medicaid policy specifically. And Senator Benning, you're very familiar with me in terms of the Medicaid administrative rules, where we're in front of the LCAR committee on a very regular basis to continue to adopt updates to our Medicaid administrative rules. And Secretary Samuelson, I really don't have much to add in terms of an overview. You did a great job really laying out the context. And as she said, we're in the middle of a negotiation. We are very much fighting for sustainability in the short term as we can figure out what next steps are and what makes most sense for Vermont and our system of care. But at this time, I think you've really covered it, Secretary.
So I'll throw in a question here, and either or both of you can answer. I understand you're in the middle of negotiations, but do we have a timeline for when negotiations are supposed to be done?
Yeah, so Vermont's 1115 waiver, we just received an extension through June of this year. And so we will be completing negotiations before the beginning of the next, in the next fiscal year, the next state fiscal year. So we will have a new 1115 waiver in place by July 1.
Okay. Committee, further questions? You may have heard some expressions of frustration. That's nothing personal. We've been involved on this committee for some time discussing things. And in my case, it was shortly after a little rainstorm called Tropical Storm Irene, when we closed down a 50-bed facility. And at that time, that facility was under the gun for not meeting federal standards. And the decision became, let's build something a lot smaller. Personally, at the time, I was arguing we should rebuild the same number. Whether that's good or bad, the frustration remains because we still haven't resolved after 12 years now the ultimate objective, which I think everybody has, to make the state a safer place. So I understand you might be taking the brunt of frustration, but the frustration is generally rooted, and we're struggling to figure out how to get from where we are to where we want to be. I'm not sure if there's any other questions for the committee, or if either of you have any general responses or thoughts. Madam Interim Secretary, are you planning to become secretary?
That's a conversation between the governor and I that are engaging in. So
Further negotiations, I understand.
Yeah. So
Well, good luck.
Thank you. Chair Benning, can I add one more component to what you, I think
Please.
one of the questions that you may want to ask is, how many beds do we have total across the state for inpatient mental health, directly related to the closure of the hospital? Right now in the state of Vermont for adult inpatient, there are 198 beds total. Right now, 122 of those are currently occupied. And so there's about 55 beds that are closed, particularly due to the COVID pandemic, but there's still 22 open. And so it's important as we think about the capacity, to understand that in some cases that there still is there is, even with the closure of the state hospital, there's been some regional inpatient beds, like at Rutland at our state hospital, and we expected other hospitals to open up. And so there is some capacity in the system, particularly for adults.
So you brought to mind another thing that happened back in 2011 or 12. The number of patients spread throughout the state. They come from various areas and are weighted in various areas. So I literally took a map of the state of Vermont, and I had the patient count spread throughout the state. And then I applied that to a map of where the facilities were. And as it turned out, all of our facilities were, I'm going to call it bottom heavy, because they were oriented toward the southern end of the state. But our patient count was all oriented toward the northern part of the state, which made no sense to me whatsoever. It's nice to know we have extra beds, but how are we with respect to the spread of the actual patient count?
Yeah, I think that's a great question. I can get back to you with more detail on where folks are. As I said before, I do expect to see some diversification of that, with proposals both on the youth bids that are out, and also with at least one or more of the hospitals who are going to put in a proposal for adult beds. That will allow us to diversify the locations and keep people closer to home.
Good to know.
Yeah.
Anything else anybody wants to say? Well, with that, Ladies, thank you very much for coming to join us this afternoon. As you know, the Capitol bill is our vehicle of getting anything accomplished, and we don't have that bill in front of us yet. It may very well be that whatever our House counterparts are doing with it results in an answer that you may have some disagreement with. And if that is the case, feel free to reach back out after a town meeting week break, and we'll have another conversation about what changes might need to be made at that time. In the meantime, thanks for joining us, and we'll wish you all a pleasant afternoon.
Thank you for having us. And likewise, I hope you get a chance to enjoy the warm weather.
Thank you. Alex,